Okay, so hello and welcome to the second last um, session or lecture for this course. So let me just put this on the slideshow. So these last two lectures are going to be uploaded versions of the course. This is the first time I'm doing it because we're running a little bit behind schedule because of a number of issues, and I wanted to make the material available to everybody who is interested. So first of all, today's discussion is going to be on biomarkers, which is sort of the last topic that we had planned for this course. And so we will be discussing the types of biomarkers, and that includes genomic, epigenomic biomarkers, different sources of biomarkers, and how relevant they are in the clinical setting. So somebody might just ask, why are we at all getting invested in this discussion? Why are we talking about biomarkers? This is a course on genes, genomes, and the epigenome. So the short answer to that is that this entire course has covered very diverse topics, starting off from very basic molecular biology, moving into epigenetics, moving into whole exome sequencing, RNA sequencing, attack sequencing, 3C, high C, all these different techniques. So we have learned the most basic concepts that are necessary for you to be able to understand how a cell works. And we have diverged into current cutting edge methods, which are necessary a, to be able to keep up with how the world is functioning, how research is working in today's time, and B, to understand how the information that you previously used to rely on can now be understood A, more comprehensively because high throughput sequencing techniques are now in place, and B, so that you understand that science is not just limited to figuring out what is inside the cell. Eventually, it does boil down to that, but the objective is for you to understand that there are so many different arenas for each and every one to explore. Um, just being very biased in one area, for example, only focusing on cell biology or only focusing on high throughput sequencing techniques, only focusing on analysis, these become very niche domains. And what eventually is going to be helpful, not just for you or me as researchers, as students, but instead for the community at large, is to be able to translate this knowledge to the clinical settings, to individuals who are actually suffering from all these diseases, and to be able to make use of all the money that is going into research. Obviously, if you are familiar with research, would learn that the monetary investment is immense. And to get sensible output of this entire expense of all of this investment is something that everybody wishes for. So, with this idea in mind, what we are going to understand today is that based on all of these techniques, all of these analysis steps, and all of these possible directions for you to explore in the future, how much of it can we actually use for clinical translation, and when you do have a concept that you actually want to translate to the clinics. Say, for example, your master's thesis or your PhD thesis is on some sort of a drug or some sort of a target, some gene that is, you have figured out to be something really important in the disease that you are trying to study. And you have figured out that you've figured out some way to target it or inhibit it, you've developed a drug, a number of possibilities exist. Now, for that to be relevant in a clinical setting, usually what you can look at is either a therapeutic strategy or you can look at some sort of a biomarker, which means that it can be used um, as an indicator for a disease. So that becomes extremely important. While it might sound like something very weak to you, but think of it as a real life example. If somebody in your family falls sick, what's the first thing that you do? You get some tests done. So in these tests, it is these biomarkers that are going to make such crucial decisions whether or not that person needs some treatment, they need to be admitted for doctor's supervision, or they need to be subjected to some sort of a therapy. All of those decisions are usually preliminarily initiated based on biomarkers. So biomarkers have a way more important role than what we actually give them credit for. So with this generic layman language background, I'm going to move forward and we're going to go into technicalities, understand definitions, and understand what is actually the translatability or the clinical applications of these techniques that we are talking about. So a biomarker by itself, by definition, is a protein, a chemical, or a metabolite, or the product of an interaction between a chemical and some sort of a molecule, or within a cell, that is measured in the human body. So there are a few key terminologies that are usually associated with a biomarker. First of all, it should be measurable. When we say measurable, it is usually in terms of a quantity, that there should be a normal, clean, defined range within which that biomarker's expression or availability within a system is expected to be present. And with respect to that range, whether there's an increase or a decrease, or there is some sort of a shift or a bias, is probably going to be something very important for disease diagnosis or prognosis, or for making very crucial decisions in that individual's entire medical journey. So using current technology, what do? You detect that protein, that chemical, or the interaction of that protein or that chemical with some sort of a test. So like just off the top of my head, ELISA, for example, which is used for diagnosing dengue, or a number of other techniques. If you ever go through lab reports or pathology reports from anybody in your family, you will find that the type of test that is usually utilized in that detection or in that strategy is usually mentioned. So that's also something you can look at and something you can learn about. And if that is something you're curious about, pathology is also a very interesting line for you to explore as a career option in the future. Um, of course, you have to be a very good technical expert at all of these techniques, but of course, the opportunities are endless. So, using modern analytical technology, it is now possible to measure a really large number of biomarkers that are present in humans. That can either be from blood, which by default, usually we talk about whenever we talk about a biomarker, because A, blood is easily accessible. Blood is considered to be non-invasive. It's not a surgical intervention to any technique. It's easy to get. It doesn't produce more risk, or does not upset an individual clinically. So it's a usually preferred route for any sort of detection, or even for any sort of diagnosis. Apart from that, there are tissues that are often also used as sources. When we talk about tissues, usually that refers to a biopsy, which, while is sometimes almost inevitable, it is invasive in nature. It does carry with itself a possibility of spreading, of metastasis, of sometimes making things worse. Many times, people, if they have some underlying condition, or if they're really old, then biopsies can be very weakening for them as a system. So it's not always the best option, but sometimes that's all you can do. So people opt for biopsy. Another non-invasive strategy for biopsy involves the use of the urine. So a lot of tests are often done in the urine. Usually, for example, um, if a if an unexpected expression of a particular chemical is found in the urine, a very common example is HCG, human chorionic gonadotrophin, which is what is utilized for all the pregnancy tests that you might be familiar with. So it's an immunoassay. It involves the use of some antibodies that agglutinate, and that gives you the final readout. But the basis lies in the fact that it's a urine-based biomarker. So if a woman is pregnant, then you would expect that HCG is present, and only then in her urine you would get a positive indication for that test. So that's just one example off the top of my head. From here, also sometimes this can be done, and so on and so forth. So biomonitoring techniques are becoming, in fact, very common tools for decision makers in health and environmental fields as well. When we talk about researchers and clinicians, which is the field that I was mentioning previously, this understanding of the type of biomarker becomes necessary, not in the same context, but instead for study design, for diagnostics, for therapeutic strategy, all of those things. So FDA and other bodies, these are health monitoring bodies. So they have defined 7 distinct categories of biomarkers. That includes first susceptibility or risk biomarkers. which means I'll define all of these later on. So let me just introduce the name. So the risk biomarker, diagnostic biomarker, which is sort of a confirmation of a particular disease, prognostic biomarker, which dictates how that disease's treatment needs to be modified further, monitoring biomarkers, which is what you expect to, when you expect a certain biomarker to behave a certain way over a period of time, predictive biomarker, which can indicate a sort of outcome under certain circumstances, pharmacodynamic or response biomarkers, safety biomarkers. These are all of the different types. So just briefly, if you look at this figure on the right, you will see a sort of an introduction. Sorry. So first is prognostic. For example, is it likely if an individual is likely to develop a certain type of cancer that can be detected? Then you have diagnostic. What type of a disease is it? Is this the most optimal drug for the cancer type that I'm studying? Um, pharmacodynamics, which is the most optimal dose for the individual that I'm treating for an individual's body based on some other parameters. Recurrence biomarkers sometimes can indicate whether an individual's cancer is possibly going to return because they are now suddenly expressing a certain unexpected biomarkers at very high levels. So these are all of the different types. So if we learn about each of these biomarker types one by one, the first is susceptibility or risk. So what do I mean by that? It basically indicates the genetic predisposition or the elevated risk of certain diseases. So many a times, we'll go over the examples, but many a times what happens is that an individual's genetic background is a decision good enough, or it provides enough leverage for an individual to be almost certain that they are going to eventually suffer from a certain disease because they have a certain biomarker, or they show the expression of a certain biomarker, or basically just a susceptibility or a genetic predisposition to a certain disease. So they predict an individual's likelihood or the possibility of that individual developing a particular disease. For example, mutations in BRCA1 or BRCA2 genes, they are associated with an increased risk of developing breast and ovarian cancer. This is something that a lot of people might be familiar with. There are a lot of female popular faces, celebrities and actors and all these individuals who have come out actively and have discussed that they have carried out genetic testing because their family has previously, a lot of women in their family have suffered from these diseases, from breast and ovarian cancer, which is often extremely life-threatening. And of course, cancer is not something, if you can prevent, you're not going to prevent. It's something you will do everything in your power to steer away from you, right? So if people do find that there is a familial trait of, or rather, the disease has some the disease has some genetic predisposition, or it can be directly tagged, or it can be directly associated with a certain uh, genetic background. And if that genetic background is something that you can see is passing down generations, then you can often sort of establish a cause and effect sort of a link. And as a result, if a certain mutation or a certain alteration is present, then it can predispose that individual to that particular disease. So testing for these mutations can identify those individuals who might benefit from increased surveillance, from risk reducing surgeries, or from targeted therapies. So, if you test these individuals, early diagnosis will be feasible, and accordingly, prognosis can be carried out. And also, even if a certain individual has yet not developed that cancer, they eventually might. And sometimes people opt for certain surgeries which are um, sort of preventive in nature in this context. When I say preventive, it is usually, for example, if somebody has a tendency to suffer from breast cancer, they sometimes do undergo double mastectomy to get rid of the breast tissue, which can develop this problem. And so there are lots of individual decisions and individual biases and individual preferences that come into play in this case. But our job is to understand how these biomarkers function, how reliable they are, and how much of clinical decision making can actually rely on them. Some other susceptibility biomarkers, they include ApoE TP53, which is a very common tumor suppressor gene. So if somebody has a TP53 mutation, almost indefinitely, you can expect that at some point in their life, they are probably going to suffer from the disease, from cancer, because TP53 is a master molecule that has a huge role to play in maintaining homeostasis within the cell. It's a tumor suppressor. It is a guardian of the genome, and it ensures that the genome is maintained in a protected state and the sanctity or the fidelity of the genome is maintained. And if that is upset, it's sometimes extremely risky. Then you have MTHFR, PALB2, HFE, etc. All of these are different types of risk biomarkers or susceptibility biomarkers. The second set involves diagnostic biomarkers. As obviously you can understand by the name, diagnostic biomarkers are those which are able to detect or they're able to confirm that an individual has a certain disease. So it can confirm the presence of a certain disease or a certain condition, and they are used to detect or to confirm the presence of that disease. Diagnostic biomarkers will also give you information about the characteristics of that disease. So we'll look at some examples. First is PSA, which is associated with the disease that I personally work on, which is prostate cancer. So PSA, or prostate specific antigen, is used in the diagnosis and the monitoring of prostate cancer both. So high levels of PSA in the circulating PSA in the blood can indicate the presence of prostate cancer, while changes over time, how like it's a sort of a curve basically can be plotted for PSA response over time. And when a person is treated with a certain drug, the consequent shift in the PSA levels can also be monitored in accordance. So, in response to that treatment, or just to monitor how disease has progressed over time. Then you have CRP, which is C-reactive protein, which is not very um, condition specific, but instead it's an indicator of inflammation in the body, C-reactive protein or CRP. So elevated levels of CRP in the blood may be associated with a lot of inflammatory diseases like rheumatoid arthritis, lupus, cardiovascular diseases, etc. Other key diagnostic biomarkers include CEA, CA125, mucin 16, NSC, AFP, troponin T, etc. All of these different biomarkers also can be used as diagnostic biomarkers in an individual. Then, so compared to diagnostic biomarkers, which are confirmatory in nature, which are going to ascertain that a certain individual has a certain disease or has progressed to a certain stage in the disease that they were initially diagnosed with. In contrast to that, when we talk about prognostic biomarkers, they do a different job. They are showing you how the disease has um, evolved over time, and therefore what is the pattern of progression that the disease has followed, and what can be the predicted disease outcome for a certain individual. So when we say disease outcome, it usually is affiliated with reference to cancer itself, and usually the reference is what it means is whether there's going to be a disease recurrence, or if the disease or if the individual is eventually going to die of the disease after diagnosis. So these biomarkers, they basically help a clinician or a doctor understand how aggressive the disease is in that individual, how much is treatment necessary. Now, somebody might ask that if a person has been diagnosed with a disease, why don't we just immediately recruit them on some treatment? The reason behind this is that sometimes for certain diseases, treatments are carry the potential to make things much worse than actually what the disease might eventually have progressed. But then it's sort of a gamble of going for the lesser of two evils. And sometimes people just opt for the treatment because they want to save their loved ones. It seems like a very obvious choice at that point of time. So, after a diagnosis has been carried out, the disease outcome or the disease predicting how the disease is eventually going to um, affect that individual, that is all dictated by the prognostic biomarker. Now, among the known ones, two very common prognostic biomarkers, especially the first one is very, very important, which is Ki67, also MKI67 is its alternative name. It is a marker of cell proliferation and is commonly used as a prognostic biomarker in general for any cancer, but specifically also in breast, prostate, and other cancers. So, more aggressive tumor, more Ki67 staining, and poorer outcomes. Next, you have BRAF, which is a gene that is frequently mutated in melanoma and a number of other cancers. Testing for BRAF mutations can help predict the response to targeted therapies like BRAF inhibitors. And patients that actually carry BRAF mutations have a better tendency of responding to these drugs. And therefore, after this initial characterization has been carried out, then executing the treatment is a better option and more effective option. Apart from this, other key prognostic biomarkers, they include P53 or TP53, HER2 or ERB2, MYC, VEGF, cyclin B1, all of these. So, so I hope the difference between diagnostic and prognostic biomarkers is also clear. Do not use them interchangeably. They are different, and the objective of, so for example, think about it in this way. Um, Suppose you present with some symptoms and your symptoms are not very directly indicative of which condition you are suffering from. So at that point of time, what does a physician do? What does a clinician do? They're going to ask you to do some tests. So that test might include that panel might include a number of tests which are possibly quite diverse, which might seem very diverse to you, but usually what they'll consist of is two or three tests that are going to judge the capacity of the organ which is being doubted by your clinician. Secondly, what it is going to do is help eliminate non-specific directions for further diagnosis. And so confirmation of diagnosis can be done with more stringency and more accuracy. And if you have already been diagnosed previously and your disease progression and the way your disease has developed or will possibly develop, that can be monitored by the prognostic biomarker, which is the second one. So each has its own job and each needs to be handled separately. So that is the difference I was trying to make you understand, because when you go for a test, it's possible that the doctor is going to make you eventually try out both these types of tests, but the sort of conclusion that you should draw should differ based on what test is being recommended. Next, we must look at monitoring biomarkers. So, um, this is sometimes a little in not interchangeably, but sometimes used both for sometimes used loosely with prognostic biomarkers. But what this specifically does is that it tracks the disease status, therapy response, or disease relapse over time. So they are measured repeatedly to assess the status of a disease or of a mental condition, or to quantify exposure to a medical product or environmental agent. Monitoring biomarkers, they play an important role in disease management and disease treatment. So it's basically to track disease progression, track disease evolution, and track the patient's progress over time. So two examples. First one is HbA1c, or hemoglobin A1c. This is a biomarker that is A, used to diagnose the disease, and B, used to monitor the disease. So a relative, for example, that I have has had very fluctuating levels of HbA1c over the last 10 years. So why is that important? You might say that over 10 years, a particular protein's expression is allowed to change. Fair enough. Why that is important is because diseases like this, once they have been diagnosed, some diseases, they have certain the treatment for these diseases, they have certain drugs that are that need to be adjusted and that need to be controlled, the dosage of which needs to be controlled over a period of time to make sure that there is no imbalance, that it doesn't affect that individual adversely. For example, let's think about the fact that sometimes people need insulin to be supplemented directly to be able to regulate their um, blood glucose levels. And if there is no doctor actually overseeing it, and if a person is subjected to insulin doses higher than what is required, then that can be extremely dangerous. The person's blood glucose level can get too low, they can become hypoglycemic, and a number of conditions can arise. So therefore, how do you make this decision that this treatment or this strategy or whatever we have thought has a certain um, has a certain control, let me put it that way. So for example, if you monitor HbA1c every 6 months, you'll get an idea of how that person's diet and lifestyle choices have evolved, and accordingly drug dosage needs to be changed to make sure that levels can be maintained. Just excuse me for a minute, I'll be back. Okay, apologies for the inconvenience. Okay, so coming back here, we were talking about monitoring biomarkers, and among them, the first example is of HbA1c, which is a biomarker used to monitor diabetes. The second example is of BNP, which is brain natriuretic peptide. Again, it is something if you have, I hope nobody has to, but if you have ever had a relative who has undergone some some heart who had some heart condition and has been hospitalized or um, is above a certain age bracket, then usually this is one of the preliminary tests that are carried out to check the heart's condition. So BNP is released by the heart in response to increased pressure and increased volume, which is indicative of heart failure. And monitoring the BNP level can usually assess the severity of heart failure and to also um, accordingly decide how treatment needs to be carried out for that individual and what possibly would be effective, what is the heart's current health, whether they should be taken off life support, whether they need life support. A lot of these decisions are made based on this. And in accompaniment, there are a few other tests that are also done. For example, that includes troponin 1, CRP, D-dimer test. These are also often done, which are also monitoring biomarkers. And usually they are done either regularly or they're done on alternate days when a person is hospitalized to track the heart's condition and accordingly make decisions whether surgery is necessary, whether life support is required. And the lungs function is also often kept right in tandem with the heart's condition, because many a times people who suffer from heart failure often eventually also have breathing troubles, and it just eventually leads to some very bad outcomes. And so monitoring these parameters, which can reflect the condition of that individual, um, systemic condition of that individual, is this can really be very helpful. So, apart from these, we also have predictive biomarkers. So, it basically predicts whether an individual is going to respond to a certain therapy. And this is, while it sounds something very fancy and very non-specific in nature, like why at all would you go for a predictive biomarker is a thought that somebody might have. But in personalized medicine, it is very crucial. It's a critical category um, that needs to be met and that needs to be determined prior to treatment, because it actually affects how a treatment decision needs to be made. So HER2 new status in breast cancer, for example, HER2, which is ERB2 new, is a protein that is overexpressed in certain types of breast cancer. So, testing for HER2 new status can actually help predict the response to certain targeted therapies such as trastuzumab, which is Herceptin. Patients with HER2 new positive breast cancer might benefit from earlier treatment with trastuzumab, which can improve patient outcomes. So, also, like apart from this, in breast cancer, also TNBC or triple negative breast cancer is also a certain subtype. So, therefore, based on the subtype classification of an individual, the type of treatment can also sometimes vary. So, these types of prerequisites should also be met before prescribing any treatment for any individual. So, yeah, so that is what the HER2 new status pretty much does. Then apart from that, you have the EGFR mutation status also in NSCLC, which is non-small cell lung cancer. So EGFR, or epidermal growth factor receptor, is a gene that's very frequently mutated in NSCLC. So checking for this status can also sort of predict the response of that individual to targeted therapies like gefitinib, which is Iressa, and alotinib, which is Tarseva. Uh, don't need to remember all this, but just so that we can understand real life applications of these techniques, I've just kept these for your reference. This was all taken from I'll share the link from which this information has all been taken. It's a very useful resource. Patients with EGFR mutations can also possibly have a better response to these drugs and might even benefit from early diagnosis and accordingly early treatment with them. Other key predictive biomarkers include KRAS, PDL1, which is CD274, ALK, NRAS, ESR1, etc. Then we have or pharmacodynamic or response biomarkers, which are often called as PD biomarkers. So the definition of this is that pharmacodynamic biomarkers, they sort of show the biological response or the mechanism of action of a drug treatment. So these biomarkers basically show um, that a biological response has occurred in an individual who has been exposed to a certain medical product or environmental agent. So they are often used in clinical trials to evaluate the efficacy or the effectiveness of new treatments. And an example of pharmacodynamic or response biomarker is the measurement of a tumor size in response to chemotherapy. So this is something that is very, very regularly done in any lab setting whenever you have proposed a certain treatment strategy or a certain genes oncogenic activity, you usually have to validate it using multiple systems. So when we talk about systems, we basically mean that a 2D cell culture system, a 3D system like patient-derived organoids. You can use mouse models or mice models, which are in vivo models for this purpose also. So there are lots of possibilities that you can actually opt for. So LDL cholesterol in cholesterol levels in response to statins. So statins are a class of drugs which are used to lower cholesterol levels in patients that have high cholesterol. The pharmacodynamic or response biomarker in this case is a reduction in LDL or low density lipoprotein cholesterol levels that occurs in response to statin treatments. So these are usually prescribed after people show initial levels of like initial, for example, if somebody has shown initial test results have shown that there's an increase in there's a decrease in the HDL LDL ratio and more LDL cholesterol is present, then statins would be prescribed in that case. Of course, it's not the first line of treatment. Usually, it is lifestyle changes, which is what is recommended, so that a person's body does not become addicted to this sort of treatment, because these are no matter what, they create a dependency in your body to these drugs. And so, how you monitor it is that you check for the reduction in this LDL cholesterol in response to statin treatment. Then, blood pressure in response to antihypertensive drugs. Almost, I guess, every second, third person that you possibly meet who is above a certain age bracket will most probably have hypertension. Again, there is a genetic basis to it as well. If your parents, if your family, elders in your family, they have hypertension, there's usually a propensity to it. Of course, if you do monitor it regularly, you would be able to keep it away. And if you have healthy lifestyle choices, that also helps. But sometimes genetics does take over. It's something you simply cannot prevent at times. So the pharmacodynamic or the response biomarker in this case would be the reduction in blood pressure that occurs in response to treatment with this drug. So other key pharmacodynamic biomarker includes CYP3A4, caspase-3, phosphorylated AKT or phospho-AKT, phospho-ERK, STAT3, HSP90, all of these. So these are other pharmacodynamic biomarkers. Then we have safety biomarkers. So again, if you just recapitulate it very quickly, the first one was a risk or a susceptibility biomarker. Just a minute. Then you had diagnostic biomarker. Then we came to prognostic biomarkers. Then we talked about monitoring biomarkers, which are used to monitor the evolution of a disease or the progression of a disease in an individual over time, so that clinical management can be decided accordingly, treatment can be decided accordingly, and that individual can be under supervised care for a very long period of time. Then we talked about predictive biomarkers, which are expected to sort of dictate how a patient is going to respond to a certain therapy. Usually, it's a very critical category in personalized medicine, and based on it, sometimes patients can be classified also into different groups, and that can affect the results of a clinical trial as well. So, it's something that also needs to be kept in mind. Then we talked about pharmacodynamic or response associated biomarkers, and we talked about safety biomarkers also. So, when we say safety biomarkers, what does it mean? So, they basically measure toxicity or adverse side effect risks, often for liver, kidney, or muscle damage, monitored especially during clinical trials, and to ensure that there are no that a particular treatment does not have very severe off-target effects or doesn't cause very extensive harm in an individual. And yeah, so that can be monitored. Then we have liver function tests for that purpose, LFTs. So they are a group of blood tests which are used to sort of measure the level of certain enzymes, some liver enzymes and proteins which are produced by the liver. So LFTs can be used as safety biomarkers to monitor liver function and to detect any drug-induced liver injury, which is called as DILI. So when your drug treatment is being carried out, that is affecting the liver, that is burdening the liver and affecting the liver. So that's actually something that any person who has been diagnosed with any lifestyle disease and has undergone extensive drug treatment, especially oral drug treatment, is something that they need to monitor, because eventually all your drug pressure, all the exhaustion of bearing that many drugs for an extended period of time, it all falls back on the liver. And so sometimes the liver does give up. And so that needs to be monitored. That needs to be ensured that it's not too harsh on the liver and that it is taken care of. So, um, yeah. So anti-hypertensive drugs, I was talking about safety biomarkers. So LFTs are a group of blood tests that detect the levels of these enzymes, all these parameters, all these proteins which are produced by the liver. They can be used as safety biomarkers to monitor the function of the liver and detect DILI, which is a potential adverse effect of certain medications. Then you have creatinine clearance, which is the measure of kidney function. So when we say creatine clearance, it monitors nephrotoxicity or toxicity to the kidney as a response to certain medications like antibiotics, like um, antihypertensive chemotherapy drugs. Usually, antihypertensive will not affect it, but chemo drugs, etc. And there are other key safety markers, biomarkers as well, which includes ALT, which is a test which is often carried out in association with with the LFT test. You have AST, creatine, albumin, which are probably included under LFT itself. I cannot recollect at the moment. Then you have CK or casein kinase, troponin C, bilirubin, etc., which all together are going to sort of represent the liver's health, although nothing, of course, is confirmatory in nature. So, yeah, that is pretty much what I wanted to discuss regarding biomarkers and the subtypes. Um, just give me a minute. Okay. So now we will discuss how genomics can be translated into clinical settings. So we discussed genomics separately in our previous classes. Next, we have discussed how important it is to be able to utilize these resources, not just for research, but for clinical applicability as well. In that context, we discussed the role of biomarkers and we discussed multiple types. Now we are trying to sort of integrate the two. So let's first understand where this entire concept came from. What I'm telling you right now, where did that concept come from? So the landmark sequencing of the human genome has ushered in a new field of large-scale research. So advances in understanding the molecular basis of disease has opened up so many new opportunities to develop genomic-based tools to diagnose, predict disease onset, predict disease recurrence, tailor treatment options, and assess treatment response. Again, understand these are all different facets. First, you want to be able to diagnose a disease properly in due time. You want to be able to predict the onset of the disease. You want to be able to predict whether the disease has a possibility of recurring. You want to accordingly, based on the progress of an individual, want to be able to dictate the treatment that should be followed for that particular individual. Then you want to be able to assess the response to that particular treatment as well. So although it is still like quite preliminary at this stage, it's still something that people are studying, are trying to optimize, are trying to um, make clinically more feasible. Still, genomic biomarker research is something that is so important, and it has the capability of providing a lot of insight into pathophysiological processes, as well as more precise predictors of outcome that were not previously attainable with traditional biomarkers. Now, before genomic biomarkers are incorporated into clinical practice, several issues will need to be addressed in order to generate the necessary levels of evidence to demonstrate analytical and clinical validity and utility. So, in addition, efforts are necessary to educate health professionals because as a researcher, it's much easier to accept these new technologies. However, to be able to implement it, um, not just in a clinical setting, but to make it acceptable to doctors, to make it acceptable to patients, their families, um, it sounds much easier than we think, and it requires a lot of investment, a lot of time, a lot of awareness. So efforts are needed, not just to standardize techniques to make them as effective as foolproof as possible. Of course, nothing in biology can be completely foolproof. We only know as much as our cells decide to tell us, and there's always scope for improvement. But anyway, best efforts by researchers, best efforts by clinicians must be considered, and the public should get to know about genomic-based tools, revise oversight mechanisms, ensure that privacy safeguards of the information generated from these new tests can all be taken into consideration. So let's look at the schematic briefly and also then understand the associated text. So you can see that discovery is only the first step. What we have discussed till now is only literally this first step. But what needs to be next taken forward is that the clinical data, the clinical efficacy of whatever data you've seen in just cells, to look at that in humans, accordingly have a predictive model, a decision support tool, and then it also, of course, something else comes in here, which includes registries by repository, health system, EHR, all of that needs to be considered before implementation can even come into question. There have to be regulatory bodies which must support whatever hypothesis you have come, not even hypothesis, whatever data you have come up with. And because at the end of the day, these are human lives, these are people, they're not just numbers on a page, they're actual human beings, and the accountability and um the impact of the work that we are doing should be quite should be something that should be taken into consideration. So after discovery of a new genomic biomarker, which is what we were talking about, the next phase requires the assembly of information into a clinico-genomic information warehouse that includes genomic information like genotypes, gene and protein and RNA expression data, as well as small molecule metabolite profiles, together with clinical data inclusive of demographics, medical and drug and family histories. The third phase is the development of the predictive model, which is what I was talking about, based on this genomics data and your clinical data. The integrated analysis, this is something so important that just looking at techniques as individual techniques is not enough. When we talk about multi-omics, it means the result that you're getting from technique A and technique B, while they might not show 100% concordance, any conclusion that you draw should be a consolidation of the results of both of these techniques and should make sense among each other. It's not always as transparent as I'm putting forth to you now, that suppose you have done a tax-seq for a sample and you have done RNA-seq for your samples, you will not always see 100% concordance. But understand this. These are your same cells. These are cells that are, say from a tissue, say from culture, say from mice, whatever. These are biological systems that are performing and existing the way they want to. We, as investigators, are trying to figure out what exactly is happening inside the cell. So, our techniques are taking snapshots of the cell at certain intervals, and at that interval, whatever picture you are seeing is the information that you're interpreting as the gospel truth. But what needs to be kept in mind? A, you need to have replicates. B, you should have statistical confidence. C, you should try to minimize batch effects. You should try and like sort of synchronize your sample as much as possible so that these biases can be avoided as much as you can. So all of these steps should be taken in concordance with the information that you already have. So like I was saying previously, the integration of analysis will actually reflect the true situation of the cell, and it will embrace the complexity of genomic data and capture the complexities of multiple interacting risk predictors and potentially conflicting risk predictors. The fourth phase, which is a decision support tool, focuses on the development of a user interface that communicates risk information to physicians and educational materials to support clinical decision making. So the final phase is the implementation phase, which includes development of the prototype diagnostic test platform, retesting of the predictor in other assembled populations. So yeah, that comes much later. So to ensure that whatever results you've gotten is not because of a population bias or for any or because of any other bias for that reason. All these statistically unbiased tests need to be performed. And once that is done, design and execution of clinical trials have to go through. Multiple clinical trials have to be taken over. That's a whole other um, feat that doctors and scientists who are also clinicians, they are able to take forward. And finally, after an appropriate policy can be developed and can be implemented, educational initiatives can be taken forward, only then can implementation really take place. Uh, Yeah, so this is what I was wanted to show you, that when you talk about biomarkers, it sounds like, okay, fine, I found some gene X and I'm going to take it to clinic. There's a lot that goes into place. Some of it I've already discussed, but this is sort of a funnel which represents that from your entire pool, what can actually go forward. And out of all this literature and all this work that every scientist is doing across the globe, it's so fascinating that so many people are dedicating their lives to science. Anybody who loves science is doing their very best. And that is the dedication that one should put forth. If that's not how much you love science, maybe you don't love it enough. So it's a big decision. It's a big step to take forward. Don't do it half-heartedly. If it's something you want to do for mankind, if it's something you want to translate to clinics for the benefit of human beings, don't do it half-heartedly. Be very sincere with your work and be very patient. So coming back to the discussion at hand, protein biomarker discovery funnels. So take think of it in this way, that suppose your whatever analysis you've done has given you a potential list of biomarkers that you obviously represent by 100%. Among them, if you can use techniques, and then you can accordingly do some assays and all, that immediately drops down to only 30%, which are going to be able to pass through um, the usage, even the usage or the assays which are done in clinics, whether or not that can be implemented, there itself it filters around 70% of the biomarkers, which is immense. Following that, you have clinical validation that considers reproducibility in independent cohorts, so that there are no racial biases, no genetic background biases, no environmental biases, none of that takes um, importance here. And from there, clinical utility needs to be validated, where prospective validation can be done in the clinical context, where in patients validation is carried out. And the final model will be used as a single score, for example, 0 to 100, which is going to be able to stratify patients. And that gives you less than 1% of all of the biomarkers that you thought about. Why I have specifically put this here? Many a times when we talk about biomarkers, we often say that it's mm, not a very reliable readout of whatever we are saying, and better biomarkers are required. I'll give you a very simple example. The disease I work on, prostate cancer, in that PSA, while initially was considered to be the gospel truth, in today's time has become a sort of conflicting topic. Why? Because PSA levels do not always completely and transparently reflect the disease condition. It's not a direct readout of the disease state. Sometimes patients with very low PSA can have very progressed disease, and vice versa, and therefore it's not a direct readout. However, if that is the case, why don't we go for so many other biomarkers that have come into research, that have been published by so many researchers? The truth is that possibly a large number of them are actually undergoing trials in today's time. Secondly, these trials, all these steps, this funnel that we just discussed, it's not reflecting um, the time that it takes for any biomarker to actually undergo these many rounds. Just think of it like an interview, that before you are to be awarded a certain fellowship, you have to undergo this many rounds of clearance. So this takes a, a lot of time. It takes years and years and years for something to be validated. So something you see in papers today, if it does eventually have to translate to clinics, it's probably going to take a decade or two for it to be actually implemented. And in contrast, um, something which has been standardized, of course, becomes much more reliable. And so that transition, while on paper seems very feasible, the practicality of it is something that does seem very challenging. So traditionally, biomarkers are defined as the marker or the indicator of a certain clinical process or a phenotype. In absence of more direct analysis, biomarkers in varying degrees can provide indirect evidence to aid in screening, diagnosis, prognosis, and monitoring of clinical events. In many cases, biomarkers can be measured from blood. Therefore, it helps us avoid costly invasive procedures. Of course, invasiveness of these procedures is something very crucial. And traditionally, biomarkers, they fall into one of three categories. They can either be protein, biochemical, or cytogenetic. Just a minute. Yeah. So proteins, biochemical and cytogenetic, largely these are the three traditional biomarker categories. Protein biomarkers, typically they are detected in the serum. So it's easy to detect. It's quite rapid. It's quite convenient. Changes in the level of enzymes, hormones, and other proteins, such as cytokines and immunoglobulins in the blood, can indicate damaged or diseased tissue or some organ dysfunction that is possibly present. For other diseases like cardiovascular diseases, the use of biomarkers has been very useful for diagnosis and prognosis. We talked about BNP, brain natriuretic peptide. We talked about the dimer test and a number of other examples, troponin C test, etc. All of these are possible. For example, yeah, it's written here, risk stratification of acute coronary syndrome is partly based on cardiac enzyme levels. Cardiac enzymes include troponin T or I, creatine kinase, MB. These are isozymes. These are common biomarkers of acute myocardial infarction. They are all representing different um, subtypes of cardiac diseases and very, very critical diseases. Why are we repeatedly talking about cardiac diseases? Because it's not easy to do any sort of invasive test with the heart. It's a huge risk. It's a life-threatening surgery, and it's not something anybody just chooses to do. Um, using a sort of representative of the heart's condition is a much smarter strategy, much less invasive strategy, and much easier to do strategy. And so people always preferably rely on biomarkers to A, diagnose any heart associated conditions, B, to be able to conclusively make any progress in the decision making procedure. So, more recently validated novel biomarker for this heart disease is brain natriuretic peptide. Protein biomarkers also include the highly sensitive CRP or C-reactive protein, fibrinogen, etc. While current data supports the use of the BNP to aid in the diagnosis of patients with heart failure in addition to other measures, currently data does remain inadequate regarding its use as a screening test for left ventricular systolic dysfunction or monitoring following treatment. When we talk about chemical tests, then the routine use of biochemical clinical testing has been a hallmark of modern medicine. Clinical chemistry testing is typically performed on blood or urine specimens. Traditional clinical chemistry profiles, such as PET metabolic profile, Chem7, provide general information that could be taken into account with a patient's clinical symptoms to ascertain and or to monitor a medical condition. More targeted tests and profiles such as blood urea nitrogen for kidney function or lipid profile or measurement using homocysteine, they provide very disease specific risk information. So biochemical testing, of course, is something you routinely would find for any individual in any lab. And yeah, it looks at certain parameters like we just discussed, and you can go for very specific markers as well. So depending on the test, protein or biochemical markers may vary. The third one is a little bit different. It is a cytogenetic biomarker. So traditionally, chromosomal analysis, it involves cell culture followed by GEMSA staining to directly visualize the chromosome number and the chromosome structure. And in general, metaphase cells, which can be induced from many tissue specimens, but most often by in the blood, bone marrow, and amniotic fluid, are required to prepare a certain standard sort of karyotype. Now, when we say a karyotype, what do we exactly expect to see there? So you expect some very characteristic banding patterns. The GEMSA stain has been taken up at those locations, which enables the identification of any translocations, insertions, duplications, or deletions. Now, near about 500 recurrent chromosomal rearrangements in cancer have been identified, and the molecular etiology of many diseases, such as neurofibromatosis, DMD, or Duchenne muscular dystrophy, has been elucidated by the detection of fortuitous chromosomal translocations that pinpoints the responsible gene or region. So while many chromosomal rearrangements were found to be diagnostic in nature, for example, the translocation between chromosome 9 and chromosome 22 in the BCR-ABL in chronic myelogenous leukemia, and T1517 in acute promyelocytic leukemia. Others might actually be indicative of poor prognosis or poor outcomes, like the amplification of cyclin D1, deletion of the P16 P14, ARF-P15 locus, um, del P 9P21 in several different cancers. So chromosomal breakpoints have actually been characterized, and most of the known chromosomal aberrations have been found in hematopoietic malignancies, whereas much fewer have been found in solid tumors. And several analytical challenges are likely to account for a small number of known chromosomal aberrations in solid tumors, such as the suboptimal quality of chromosomes for selection, very advanced chromosomal aberrations by the time of biopsy testing. So basically, what we are trying to say is that traditionally, cytogenetic biomarkers are usually utilized for some very well studied genetic diseases. So they are majorly something that has possibly been passed on by the parent. And you will see majorly these diseases these alterations or these chromosomal translocations or these changes in cyto band formation in certain cancers. Some gene fusions do take place, some chromosomal fusions or chromosomal translocation, reciprocal translocation, all of that can take place. And so the type of banding pattern you would possibly see in that case would be extremely different compared to, when it's extremely different, it means something which is very distinctively different between two individuals, especially this you would see if there is a sort of false coloration also that is added along with it. Like if you see here, you can see that each of the chromosomes have been differently colored for easy understanding. And like you can see here, some changes have occurred. And usually the way in which these translocations are written is in this format where T9,22 BCR-ABL is diagnostic in nature. Be back in 2 minutes. Okay. So, like I was saying, that currently, yeah. So currently, more than 275 such chromosomal breakpoints have actually been characterized, and most of them have been these have been found in case of hematopoietic malignancies. Particularly, we looked at two examples, one of which is the BCR-ABL one, which you can find here in a chronic myelogenous leukemia, and the second one is translocation between chromosomes 15 and 17 in acute promyelocytic leukemia, which are both indicating poor prognosis and possible disease onset. And also sometimes you can have deletion as well in certain loci, which can also become an oncogenic event. Now, most of the known chromosomal aberrations have been found in hematopoietic malignancies, whereas much lesser, substantially lesser, have been validated in solid tumors. So Several analytical challenges are likely to account for the small number of known chromosomal aberrations in solid tumors, such as the suboptimal quality. For example, the way in which your staining has been done at the time of isolation, chromosomes were not properly isolated. They were not the the plate on which, or the slide on which karyotyping needs to be done, it was not done properly. Advanced state of chromosomal aberrations can be present. A lot of possibilities exist. Now, although traditional chromosomal banding pattern techniques or banding techniques have actually provided an immense wealth of information, the scale of resolution of cytogenetic technologies has substantially increased. Sophisticated fluorescence in situ hybridization or FISH assays have actually currently enabled way more precise detection and genetic analysis of chromosomal rearrangements, duplications, deletions, etc. New cytogenetic techniques also enable the analysis of cells at different cell cycle stages, metaphase and interphase fish, and new colorimetric displays, spectral karyotyping or multicolor fish. Many of these new technologies are still limited to research use only, but ongoing validation and improvement will possibly result in replacement of current assays. So, yeah, currently cytogenetic assays are very case specific. They're not the most default option. Oh, sorry, not the most default option that you possibly will go for. Next come genomic and epigenomic biomarkers, which is what I actually want to convey very strongly to you, because we have learned so much about genomics and genomic techniques and the steps that need to be done in analysis. So we have gone a full circle. We started with understanding the genome, then we understood how these genomic techniques work, like mm, the science behind the genomic techniques, the companies which actually do it for you. Um, then we moved on to how these genomic techniques can actually be taken forward. Like you can combine certain techniques, you can combine sequencing with something else. We understood how you can analyze the sequencing data. What is your raw data that you get? What are the analysis pipeline steps that you should traditionally follow. Of course, that requires optimization based on your sample and based on whatever conditions you're taking into consideration. And finally, you get your list of biomarkers, you get your list of target molecules. Now, in today's molecular age, biomarkers have become exceedingly refined, and detection of single nucleotide polymorphisms, SNPs, or quantification of gene expression in anywhere from a single gene up to hundreds of genes and thousands of genes are typical of current clinical research studies. For example, a recent study assayed more than 11,000 SNPs and found four SNPs that are associated with the risk of myocardial infarction. So high throughput technologies like direct sequencing, various genotyping platforms, microarrays, all of these, they enable rapid and very accurate analysis from very small quantities of blood or tissue. Like imagine currently we do single cell sequencing. So it's insane. You can the amount of information that you can get is insane beyond imagination. And so over time, we can expect these to become way more cool, um, way more informative, way more accurate. Probably will get rid of as much background noise as possible. And it's going to be an exciting time to be part of genomics in the future. So uh, if you look at the types of genomic markers, first, of course, are DNA biomarkers. So because the human genome underwent sequencing, it has provided us with a template to map genetic variation. So more than 10 million SNPs, which is an insane number, have been identified. SNPs, again, are single nucleotide polymorphisms, one base variation within a population. But it's not a mutation. That's the difference between a polymorphism and a mutation. Again, please go back to initial lectures if there's some confusion regarding it. In the next class, when I just sort of summarize the entire course, maybe we'll brush over that as well, or maybe we'll resume from the parts we have not revisited recently since our last exam. Estimated to occur once every 1100 base pairs and at higher frequencies in gene-rich regions. SNPs have been associated with many phenotypes over the last decade. Sometimes they can cause single base change or which leads to an amino acid change, no change at all, or it might fall into an intergenic region. All of these possibilities persist. Any one of these types of SNPs might lead to some disease due to changes in protein structure and or function as a result of amino acid changes or alternative splicing or in protein quantity due to altered transcription factor binding sites or other regulatory disruptions. Second is RNA. RNA, some issue. Yeah. So gene expression data or transcriptome sequencing data has also given us an idea about the overall transcriptional activity as affected by variation, by regulatory controls, by environmental influences, all of these. Especially in context of cancer, the addition of gene expression data to histopathological analysis, which is what is traditionally followed, it it adds so much weightage to the data that you're seeing. It's giving you a more comprehensive view. Instead of just looking at one gene alteration, you are looking at an overall change in the transcriptome or in the cystrome if your target is also a sort of transcriptional regulator. So all of that information is now available. Particularly, more importantly, in cancer, this has been an immense change and is something that is now readily being accepted in clinical settings as well. Previously, microarrays were also used as a tool to measure genome-wide changes in gene expression. However, it's we are switching slowly to RNA-seq. Older platforms like qPCR are also used for smaller gene sets, but for more high throughput data, more comprehensive data, RNA-seq is the way to go. Now, patterns of genetic variation and or expression are known to compose a molecular profile or signature. Sometimes it's a little unclear what the relationship between genes of a certain profile is and whether or not they are actually part of the same network relevant to your disease pathophysiology. For example, a gene expression profile of 16 cancer-related genes has been associated with the risk of breast cancer recurrence, but it's not yet clear how each of these genes function. So whether it's separately or together or in the pathophysiology of breast cancer, all of that is a little um, difficult to say. Finally, I think this is going to be the last slide for this class. We come to epigenomic biomarkers. Now, what do we mean by that? When we talked about genomic biomarkers, we talked about changes in the genome itself. And as a consequence, also in the RNA itself. So DNA and RNA biomarkers directly without any alterations can be used, have been previously suggested, and possibly will also get implemented strongly as well. But when we talk about epigenomic biomarkers, we go a step above. So, in addition to gene variation, gene expression, genomic biomarkers, they also can include this sort of umbrella term of epigenetic changes, which includes methylation, phosphorylation, acetylation. These DNA modifications are also very crucial contributors to change in gene expression, and they have been also linked to certain diseases. So, yeah, have also been linked to certain diseases. For example, study of various human cancers have elucidated the importance of methylation to gene expression and disease status. Aberrant methylation patterns might be detected in large chromosomal regions like centromeres, like global methylation, or gene or sequence-specific methylation of CPG islets. The Human Epigenome Project, it aims to discover and understand the significance of these DNA methylation patterns. So that's a very hot topic. It's a very interesting and very cool topic as well. And yeah, that's what it aims to do. Methylation patterns, you should not take them lightly at all. They are believed to be early indicators of precancerous development. Hyper and hypomethylation both can have very important roles. It's a very interesting field, and we'll learn more about it in the future. They are considered to be early indicators of precancerous developments and could serve as cancer diagnostic biomarkers. Several methods can be used to detect gene-specific methylation changes, such as methylation-specific polymerase chain reaction, bisulfite sequencing, methylation-sensitive single nucleotide primer extension, etc. Due to the clinical significance of methylation as a biomarker, newer methods have been developed using MS instruments, mass array systems, sequenome, ink, etc., fluorescence quantification detection using methylite, and real-time PCR. Similarly, several techniques to detect genome-wide methylation patterns have also been developed, such as reverse phase, high-performance liquid chromatography, and differential methylation hybridization. So, So on the right, you see this representation of epigenetic biomarkers that includes DNA methylation, which is what I just talked about. There are histone modifications also. There's chromatin structure, non-coding RNA, RNA methylation. All of these also are taken into consideration for disease susceptibility and preventative medicine. Um, and epigenetic biomarkers, usually what people are now currently looking at are strategies which are more non-invasive in nature, although primary tissue biopsy is also carried out. Invasive tissue samples from adipose tissue or smooth muscle tissue, all of those are also taken. Apart from that, you can do fluid biopsy as well from the lungs or from the CSF, from which information is also collected. But non-invasive strategies, including blood-based collection on stool, saliva, urine, all of these are also being explored. So currently, epigenomic biomarkers are also very interesting areas of study. You can learn as much as you want about it. Um, how far it can be used as a tracker or as a prognostic biomarker still remains a debatable topic. It's something that's actively being searched for. Mainly, it's a diagnostic test largely, and also disease progression sometimes can be maintained, but the outcome is not very easy to conclude with respect to genetic biomarkers. But again, the sky's the limit, and in a few years, we might see a completely different scenario, and epigenetic biomarkers might just become the most default route for treatment. But currently, they are under study. There's so much research going on in this context, and if it's something that's interesting to you, you should definitely go ahead and explore it. You can find a lot of research in different cancers being carried out um, by research groups which have a sort of a clinical backing as well to test and validate in patients, at least in a pilot group, and then implement whatever results are actually seen to a larger cohort. So yeah, so that's pretty much it. That's I think my last slide for this class. Yeah. So basically, to sum it up, we have been discussing a lot about biomarkers. We learned the different types. We understood how they are classified. We understood the significance of biomarkers, why we are bothered about all of it. We understood the difference between these different subclasses. We understood what is the clinical relevance of having a biomarker. Why can't we just go ahead and give a treatment to a patient? It's not going to be effective and it's not ethically correct as well. Then we understood the different types and the different stages, stage-based biomarkers also. We understood how at each stage it might actually be different, and you have to switch your monitoring strategy over time. Uh, we understood pharmacodynamic markers also that included tumor size. We understood safety biomarkers also, which are usually companion tests that are done in addition to your original tests for added validation. Then we understood the challenges that come into actually translating genomics into clinical settings, even after integrating multi-omic data, how far you can actually take it to take it from bench to bedside. It's not a simple two-letter word. It's actually years and years of dedication, of hard work, of understanding how the system works and abiding by rules, abiding by ethical guidelines, because there are patients, humans involved, and still trying to do the best for them. So it's a difficult walk to begin, but an extremely rewarding one if you can get to the end of it. Then we understood the protein biomarker discovery funnel. We understood how from a pool of 100 different biomarkers, even less than one will possibly get selected. And it's a far cry from showing something in a scientific study. And by itself, carrying out that scientific study is an immense challenge. But to get it to an approved approval, even get it close to an approval is a huge challenge. So that's a major bottleneck that any individual possibly faces. And then you have protein and chemical biomarkers, which all are under the purview of traditional biomarkers. And we also have, right after that, we have cytogenetic ones as well, which are usually associated with hematological malignancies. But again, that differs from case to case. And then we have genomic biomarkers, DNA, RNA based. And finally, we ended our discussion with epigenomic biomarkers, which are the most current hot topic for biomarker discovery and possibly will lead to some really interesting results in the upcoming future. So with this, I am going to end this class. In the last class, we are going to focus our discussion in a more comprehensive manner. We're going to sum up this entire course. I tried to connect as much of it as possible, but still, I'm going to try and do a better job nonetheless. We will summarize everything we have learned during the course, and if I have missed out on something when I was teaching, I'll incorporate that as well. So it'll be like a complete recap of the entire course, which is hopefully going to be useful for somebody in the long run if they ever want to come back to the classes. But yeah, that's pretty much everything I wanted to discuss for today. So thank you so much for joining. Thank you for being a part of this course. Um, I will be signing off in the next session. So thank you and good night.